I hope you've got your coffee ready, because in this sketch, we'll be tackling hyperthyroidism, a broad ranging condition characterized by the excessive production of thyroid hormone. And just like that coffee, it really does make the body hyper. In our last sketch, we watched as our suave and sophisticated secret agent beat up the baddies and rescued the hospital from the machinations of the evil Dr. Hashimoto. Well, he's back for the all important sequel. One that gives you hope in the possibility of a long running movie franchise, not the quick cash grab that heads straight to the bargain bin at the gas station. As you undoubtedly know by now, thyroid hormones regulate a bunch of the body's physiologic processes. If you've seen our previous sketch on hypothyroidism, you know that a lack of thyroid hormones slows everything down. It won't surprise you then to hear that hyperthyroidism speeds all of these processes up. Our recurring sketchy symbol for hyperthyroidism is the big red bow tie, this time worn by this evil henchman. I wonder what he's setting up for. Oh, well, that makes sense. In any case, those time bombs nailed up high on the cemetery wall represent elevated thyroid hormone, the defining feature of hyperthyroidism. In most cases of overt hyperthyroidism, both T4, represented by the time bomb set to 4 minutes, and T3, represented by the one set to 359, are elevated. Let's take a look at the common presenting symptoms of hyperthyroidism. Spoiler alert: since thyroid hormones affect virtually every organ system in the body, hyperthyroidism can present with a wide variety of symptoms. High levels of circulating thyroid hormone increases adrenergic sensitivity, resulting in a feeling of nervousness, anxiety, or jitteriness that you'd feel if you had a rush of adrenaline. Kind of like what this lady must be feeling right about now. Come on, guys. Blowing up a lady in a cemetery? Boring. Or super efficient. Can't decide. Thyroid hormone also stimulates thermogenesis, leading many patients to present with heat intolerance, represented by this woman's red face turning away from that flaming torch. Similarly, patients may report excessive sweating, aka diaphoresis. Either way, they just can't take the heat. Thyroid hormone increases thermogenesis by increasing the body's basal metabolic rate, which can also cause weight loss despite having an increased appetite. To help you remember this, just take a look at this thin, ravenous attack dog nipping, okay, chomping, at the lady hostage's dress. Somebody's hungry. Just like how it speeds up metabolism, excess thyroid hormone will rev up the heart as well. The end result is increased heart rate, contractility, and tachyarrhythmias, all of which commonly cause patients with hyperthyroidism to present with palpitations, represented by our lady hostage shaking with fear. Thyroid hormone also stimulates GI motility, leading patients to have increased frequency of bowel movements, aka hyperdefecation. Such a fun, graphic word. Anywho, we've represented hyperdefecation by those brown puddles of mud. Yeah, sure. Beneath the hostage. Hey, it's underneath the rabid dog, too. Because, fun fact, hyperdefecation also contributes to the weight loss that's seen in most patients with hyperthyroidism. Most of the symptoms we've described so far are kind of the opposite of what you'd expect to see in a patient with hypothyroidism. And that makes sense. By the way, check out our sketch on hypothyroidism if you haven't yet. However, hyperthyroidism can also produce symptoms that are similar to the ones you'd see in hypothyroidism. Like hypothyroidism, untreated hyperthyroidism can also produce proximal muscle weakness, manifesting in patients as difficulty raising their arms overhead or getting up from a seated position. Just take a look at that hostage struggling to keep her arm up. And those irregular pools of blood by her feet? Yep, they represent abnormal menstruation, which can affect women with hyperthyroidism as well. Just like in hypothyroidism, these menstrual abnormalities frequently lead to anovulation and infertility that's reversible with the treatment of the hyperthyroidism. Uh-oh, it's never a good thing when your captor's eyes go into swirly mode. Our recurring sketchy symbol for psychiatric symptoms. Just like hypothyroidism, patients with hyperthyroidism can experience a wide variety of behavioral and personality disturbances, such as insomnia, agitation, psychosis, and depression. So keep thyroid dysfunction on your differential for anyone coming in with new psychiatric symptoms. Now that you know what patients with hyperthyroidism present with, let's talk about why they're hyperthyroid. By far, Graves' disease is the most common cause of hyperthyroidism overall. At Sketchy, Graves' disease is represented by this young woman being dragged into that underground grave by the evil henchman. She's young because Graves' disease most commonly occurs in younger women. Graves' disease is an autoimmune disease that causes hyperthyroidism through the production of activating TSH receptor antibodies that stimulate thyroid hormone synthesis and secretion. Represented by these antibody shaped electrodes attached to the neck of the hostage. Creatively inhumane. Just what I'd expect from a secret agent's arch nemesis. Graves' disease is associated with the presence of other autoimmune diseases like multiple sclerosis, pernicious anemia, and vitiligo. So make sure to ask about thyroid dysfunction if your patient has a history of autoimmune disease. Check out that creepy old undertaker. What? Women can be undertakers too. Hashtag feminism. Anywho, those gravestones of all different sizes represent toxic multinodular goiter, one of the most common causes of hyperthyroidism in older women. Toxic multinodular goiter is caused by diffuse hyperplasia of thyroid follicular cells that have gone rogue, autonomously producing lots of thyroid hormone independent of regulation by TSH. If toxic multinodular goiter is caused by diffuse thyroid follicular hyperplasia, then toxic adenoma is its counterpart, caused by focal hyperplasia of thyroid follicular cells. In this case, the result is a single nodule autonomously producing thyroid hormone, represented by this single giant grave with a big @ sign on it. Graves' disease and toxic nodular thyroid disease aren't likely to go away on their own. However, as with hypothyroidism, a number of conditions can cause transient hyperthyroidism that tends to resolve spontaneously without intervention. Certain forms of thyroiditis, represented by this dude's flaming red bow tie, can cause transient hyperthyroidism. You might remember a similar phenomenon from our last sketch on hypothyroidism, but what happens is inflammation initially results in lysis of thyroid follicular cells, spilling a bunch of thyroid hormone into the circulation, leading to hyperthyroidism, hence the peak in this sine wave shaped gait. After a few weeks, as these thyroid hormones become depleted, hyperthyroidism gives way to hypothyroidism, and the trough in that sine wave. In most cases, thyroid function returns to baseline within a year, just like how the sine wave ends up where it started. Let's take a look at some of the forms of thyroiditis that can cause transient hyperthyroidism. If you've watched our previous sketch on hypothyroidism, this will sound pretty familiar. The most well known cause of transient hyperthyroidism is subacute, aka D. curvans, thyroiditis. Subacute thyroiditis is represented by the statue of a woman kneeling beneath the statue of that cute baby. Why is she blowing her nose? Well, that's because subacute thyroiditis is thought to be caused by a post viral inflammatory process. So ask about a recent history of viral URI symptoms. Painless thyroiditis is considered a variant of chronic autoimmune thyroiditis and is characterized primarily by transient hyperthyroidism, followed sometimes by hypothyroidism, and finally, recovery to baseline. Because it's also known as silent thyroiditis, we've represented painless thyroiditis by the statue of a woman shushing her baby. And that baby? It too symbolizes a form of thyroiditis that can cause transient hyperthyroidism, postpartum thyroiditis. Postpartum thyroiditis is virtually identical to silent thyroiditis, except that, by definition, it occurs in women who have given birth within the past year. Graves' disease, toxic nodular thyroid disease, and thyroiditis are your most common causes of hyperthyroidism overall. Let's finish up this section with some of the less common causes that you might be asked about. One of the weirder causes of hyperthyroidism is known as ectopic hyperthyroidism, which is caused by thyroid hormone production outside the confines of the thyroid gland. The most straightforward way this can occur is through functioning thyroid cancer metastases, represented by our recurring sketchy symbol, the cancer crab. Another classic example is struma ovarii, in which functioning thyroid tissue is present in ovarian cancer, hence the two ovary shaped mushrooms popping out of the ground there. Ectopic hyperthyroidism doesn't always involve endogenous production of thyroid hormone, however. Excess thyroid hormone can also come from exogenous sources, such as a levothyroxine overdose or intake of unregulated weight loss supplements containing thyroid hormone. Either way, we're talking synthetic thyroid hormone coming into the body, represented by these T4 synthetic explosives strewn about the ground here. While we're on the topic of medications, let's look at a few other drugs that can cause hyperthyroidism. The first and most logical drug that can cause hyperthyroidism is, well, iodine. While it's uncommon, iodine induced hyperthyroidism can develop after administration of IV contrast agents used for angiography or CT, hence our recurring symbol for contrast. The contrasty yin yang on this gravestone. Another drug that's classically associated with thyroid dysfunction is amiodarone, a class 3 antiarrhythmic, represented by our recurring sketchy symbol, the amiodarone amigo. Rest in peace, buddy. Pour some out for one's homie. You might not know this, but a typical daily dose of amiodarone contains 50 times the amount of iodine found in the average American diet. As you might imagine, the high iodine content can cause hyperthyroidism in patients with subclinical Graves or nodular thyroid disease. In addition, amiodarone can also cause a destructive thyroiditis that results in excess release of thyroid hormone, leading to a transient hyperthyroidism. As you may recall from our last sketch, amiodarone can cause hypothyroidism too. It's just all around bad for the gland. Now that you're up to speed on the causes of hyperthyroidism, let's move on to the findings you should look for in your evaluation. As mentioned earlier, hyperthyroidism commonly causes tachycardia, among other cardiac effects, including atrial fibrillation, represented by the irregularly irregular signal on this henchman's briefcase laptop. Additionally, the increased cardiac contractility seen in hyperthyroidism causes systolic hypertension, represented by the steam coming out of this henchman's ears. Calm down, dude. It's just a bad signal. Try, holding it up in the air. Remember from our last sketch how hypothyroidism causes diastolic hypertension due to increased systemic vascular resistance? Well, hyperthyroidism turns that on its ear, with decreased SVR contributing to a widened pulse pressure when taken in conjunction with systolic hypertension. Indeed, many of the exam findings you'll see in a patient with hyperthyroidism are kind of just the opposite of what you'd see in someone with hypothyroidism. That means instead of cool, dry skin, patients with hyperthyroidism have warm, moist skin due to increased blood flow and thermogenesis. In addition, tremor, represented by this woman's shaky hand, is commonly seen. The tremor itself resembles an exaggerated physiologic tremor and is thought to be due to increased adrenergic activity. If you notice your patient staring at you, it's not because you have something on your face. Staring and lid lag occur in all patients with hyperthyroidism. What is lid lag, you ask? Well, just like the sympathetic statue, it's defined as visible sclera above the iris as the patient looks downward. Oh, and don't forget to do a comprehensive neuro exam. As that huge reflex hammer suggests, hyperthyroidism is classically associated with hyperreflexia. However, patients will frequently have normal reflexes, so it's not a sensitive exam finding. I know, you've been waiting for it this whole sketch. Let's talk about the most well known sign of thyroid disease, goiter. The specific features of the goiter, specifically how the gland is enlarged and whether it's tender, can tell us a lot about the underlying etiology. Graves' disease typically produces a non tender, diffusely enlarged thyroid, represented by the smooth metal collar around this hostage's neck. In contrast, patients with toxic multinodular goiter present with a non tender goiter that's irregularly enlarged with palpable nodules on exam, represented by the multiple nodular knots on the headscarf of that old lady undertaker. Finally, a single non tender thyroid nodule is the classic finding of a toxic adenoma, hence the single big circular cross on this giant gravestone. Lastly, we can't forget the outlier in the group, subacute thyroiditis. Unlike what you might see in Graves' or toxic nodular thyroid disease, the goiter of subacute thyroiditis is exquisitely tender, which is why this dude with the flaming bow tie looks like he's in so much pain. The thyroid gland itself, if your patient even allows you to touch it, is diffusely enlarged on exam. Before we move on to the physical exam, let's focus a bit more on Graves' disease, since, well, it's the most common cause of hyperthyroidism, but also because test riders love to ask about it. Graves' disease is classically associated with a triad of exam findings. We've already mentioned one of them, a non tender diffuse goiter. The second component of the Graves' disease triad is ophthalmopathy, represented by our recurring sketchy symbol, the protruding goggles. Those protruding goggles represent proptosis, the most well known sign of Graves' ophthalmopathy. Other findings include diplopia, impaired eye convergence, and corneal irritation. Graves' ophthalmopathy is caused by stimulation of T cells and fibroblasts by thyrotropin receptor autoantibodies, which leads to inflammation of the extraocular muscles and orbital tissue expansion. The last leg of the Graves' disease triad is pretibial myxedema, also known as infiltrative dermopathy. Pretibial myxedema, represented by those shin high boots worn by our lady hostage, très chic, by the way, is characterized by bilateral, asymmetric, non pitting edema that most commonly occurs over the pretibial areas of the lower legs. Once again, it's caused by stimulation of fibroblasts by those TRAB autoantibodies, leading to accumulation of glycosaminoglycans in the dermis and subsequent edema. By the end of the physical exam, you should have a pretty strong suspicion that your patient has hyperthyroidism. To cinch the diagnosis, it's time to order some labs. In most patients with symptoms or signs suggestive of hyperthyroidism, a serum thyroid stimulating hormone level should be the initial test. That's because a low TSH, represented by this creepy guy with a tiny red bow tie, is the most sensitive indicator of primary hyperthyroidism, which accounts for the vast majority of cases of hyperthyroidism. TSH is low, typically less than zero point 0.5 microunits per milliliter, in primary hyperthyroidism because the primary derangement is excessive thyroid hormone levels. Therefore, due to negative feedback inhibition, the pituitary dramatically drops TSH secretion in a futile attempt to keep the thyroid from producing more hormones. As is the case with the diagnosis of hypothyroidism, an abnormal TSH should lead to a reflex free T4 level to determine if overt primary hyperthyroidism is present. A high serum free T4 level establishes the diagnosis of hyperthyroidism. At Sketchy, the free T4 level is represented by the time bomb set to 4 minutes, set high atop this gravestone to represent a high free T4 level. As you might expect, however, that's not all there is to this story. This 4-minute time bomb resting on the ground represents a normal free T4 level, which, when seen in a patient with a low TSH, indicates subclinical hyperthyroidism. Patients with subclinical hyperthyroidism typically have no clinical manifestations, and most cases are found through routine thyroid function screening. Central hyperthyroidism is a super rare cause of hyperthyroidism, but it still needs to be discussed. The most common cause of central hyperthyroidism is a TSH secreting pituitary adenoma, represented by this big red ad sign on the creepy henchman's top hat. Central hyperthyroidism, also known as TSH induced hyperthyroidism, is characterized by elevated levels of T3 or T4, and most importantly, a serum TSH level that's not appropriately low given the high thyroid hormone levels. Classically, like on exams, you'll see a high TSH in TSH induced hyperthyroidism, but a normal TSH in the setting of high free T4 should raise red flags as well. We call this an inappropriately normal TSH level. Once you've diagnosed hyperthyroidism, your next step is to figure out the cause. Remember these antibody shaped electrodes on the collar of our Graves' disease woman? They represent thyrotropin receptor antibodies, and should be the first test you should order in most patients with lab evidence of primary hyperthyroidism. A positive TRAB test result confirms the diagnosis of Graves' disease. If the TRAB is negative, or if you suspect the patient has some other cause of primary hyperthyroidism besides Graves' disease, your next step should be to order a 24-hour radioactive iodine uptake study, represented by this vial of green radioactive liquid. Radioactive iodine uptake studies can identify the different causes of primary hyperthyroidism based on the thyroid's uptake of radio-labeled iodine. Let's start with the diseases that result in elevated radioactive iodine uptake. In patients with primary hyperthyroidism, increased radioiodine uptake indicates that the thyroid is actively synthesizing more hormone. Now, which of the conditions we've talked about do that? In Graves' disease, you'll see diffusely increased radioiodine uptake. In toxic multinodular goiter, you'll see multiple patches of increased uptake, represented by these patches of green radioactive liquid oozing on these multiple gravestones. Interestingly, the other parts of the thyroid will actually demonstrate decreased uptake. That's because the non autonomous parts of the thyroid are still responsive to TSH, and since the pituitary isn't producing any, due to the glut of thyroid hormone already being produced, those regions atrophy as a result. Lastly, toxic adenoma will produce a single site of increased uptake, hence the vial of green radioactive liquid held high above the single giant gravestone. Just like in toxic multinodular goiter, the rest of the thyroid will demonstrate decreased uptake and appear dark on the scan. So, the three most common causes of hyperthyroidism also happen to have increased radioactive iodine uptake. Neat! Now let's take a look at the conditions associated with decreased uptake. Short answer, it's everything else. Hyperthyroidism with low radioiodine uptake, represented by this empty broken vial, indicates that the excess thyroid hormone is not from increased synthesis. Instead, it points to conditions that cause inflammation and destruction of thyroid tissue, such as the trio of thyroidities that cause transient hyperthyroidism, ectopic hyperthyroidism, such as thyroid cancer, metastases, or struma ovarii, or exogenous hyperthyroidism, such as factitious thyroid hormone intake or medication effects. Let's sum up the clinical presentation of hyperthyroidism in a sample assessment statement. Miss Simonova is a 34-year-old woman who presents with weight loss, palpitations, and diarrhea for the past 4 months. She also complains of difficulty sleeping and fatigue. Physical exam is significant for hand tremors, lid lag, and a non tender, diffusely enlarged thyroid gland. Labs are significant for low TSH and an elevated free T4. Miss Simonova's lab findings indicate primary hyperthyroidism, and given her exam findings, the most likely cause is Graves' disease. Perfect! Now that you've made the diagnosis of hyperthyroidism, it's time to treat your patient. There are two goals when it comes to management of hyperthyroidism: symptom control and treating the underlying cause. Let's start with step one. A beta blocker, such as atenolol or propranolol, represented by our recurring sketchy symbol, the muted beta bugles played by those cherubs, should be started in most patients as soon as the diagnosis of hyperthyroidism is made, even before you figure out the exact cause. Beta blockers effectively treat symptoms related to increased beta adrenergic tone, like palpitations, tachycardia, anxiety, and heat intolerance. Once you've initiated symptomatic control, the next step is to diagnose and treat the underlying cause. Here, we'll focus on the big three: Graves' disease, toxic multinodular goiter, and toxic adenoma, since they're what you'll see in your patient the vast majority of the time. In general, there are three commonly used options to decrease thyroid hormone synthesis: thionamides, radioiodine therapy, and surgery. Because there's no one best treatment for everyone, we'll talk about the specific instances in which each of these options would be preferred over the others. For Graves' disease, thionamides, such as propethiouracil, represented by the pistol held by our secret agent, and methimazole, represented by all the math on that chalkboard down in that secret layer, are the initial therapy of choice in patients with mild hyperthyroidism, older patients, or pregnant patients. Thionamides can also be given to achieve a euthyroid state before moving to radioiodine therapy or thyroidectomy. Methimazole is preferred over PTU in most patients due to PTU's black box warning for severe hepatotoxicity. However, that doesn't mean methimazole is always the choice. See how 001 is shooting his trusty PTU pistol at the evil henchman, protecting this pregnant bystander? That's to remind you that PTU is still the therapy of choice for pregnant patients in their first trimester. We use PTU early on in pregnancy because methimazole carries a greater risk of teratogenicity. Both methimazole and PTU are associated with an increased risk of agranulocytosis, represented by the sand timer full of granules of white sand. Thionamides are super convenient, but unfortunately, they're not very effective at achieving permanent remission. That's why, for most patients with more severe disease, definitive treatment with radioiodine therapy or thyroidectomy is required. Radioiodine therapy, represented by this case of green vials being rushed in by that secret agent, is the preferred definitive treatment for most non pregnant patients with hyperthyroidism. Radioiodine induces thyroid tissue damage, resulting in ablation of the thyroid within weeks to months, represented by the undone bow tie on this evil henchman. Done in just by the glow of the green vials? What a weak henchman. Go back to henchman school, henchman. One of the most well known complications of radioiodine therapy is, well, hypothyroidism, ironically requiring levothyroxine supplementation, represented by the T4 synthetic explosive on his cummerbund. One situation in which you should not use radioiodine therapy is in patients with moderate to severe Graves' ophthalmopathy. That's because radioiodine therapy has been shown to transiently worsen ophthalmopathy due to an increase in thyrotropin receptor autoantibodies following treatment that can persist for up to a year. To prevent worsening of ophthalmopathy, give oral glucocorticoids like prednisone, represented by our recurring sketchy symbol, the moon face discs, to patients with mild Graves' ophthalmopathy who receive radioiodine therapy. That'll teach you to abduct women wearing creepy goggles, you creep. Remember, patients with moderate to severe Graves' ophthalmopathy should not receive radioiodine. Speaking of patients who shouldn't receive radioiodine, radioiodine is also contraindicated in pregnancy. Hence the red X taped over this case of green vials sitting next to the pregnant woman. Get it? X for pregnancy category X. Last but not least, there's the least popular therapy, thyroidectomy. Still, thyroidectomy, represented by our recurring sketchy symbol, the surgery scalpel, is the preferred option for patients with super large obstructive goiters, represented by the extra large knot on this henchman's red bow tie. Don't worry, kids. He is just sleeping. Additionally, thyroidectomy is indicated for patients with moderate to severe Graves' ophthalmopathy, hence the extra long protruding goggles he's wearing, as well as pregnant patients who are allergic to thionamides and have no other treatment option. As you might imagine, cutting out the thyroid is probably going to lead to permanent hypothyroidism requiring levothyroxine therapy. That, in addition to other complications such as recurrent laryngeal nerve injury and parathyroid injury, is why surgery is not the first line therapy for most patients. We've focused primarily on the management of Graves' disease, but the treatment of toxic multinodular goiter and toxic adenoma are virtually identical. The only difference is that thionamides are not commonly used in the management of toxic nodular thyroid disease. Woohoo! Now you're a bona fide expert on hyperthyroidism. Before we wrap up this sketch, let's briefly talk about a form of hyperthyroidism that's a true emergency: thyroid storm. And to do that, it's time to introduce the evilest villain of them all, Dr. Storm. Dun 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 indeed. Because thyroid storm is a rare, life threatening condition characterized by the clinical manifestations of hyperthyroidism, only much more severe. It's a true blue medical emergency. Unsurprisingly, thyroid storm occurs in patients with undiagnosed or inadequately treated hyperthyroidism. That's why both Dr. Storm and his pilot are wearing big red bow ties. See that big red trigger on the pilot's joystick? That's our recurring sketchy symbol for acute triggers. And it's there to remind you that thyroid storm is usually triggered by an acute event like surgery, trauma, infection, or a big iodine load, such as a bolus of IV contrast. The classic presenting symptoms of thyroid storm are very similar to those of hyperthyroidism, only a lot more severe. One hallmark of thyroid storm, however, is altered mentation, represented by the recurring swirly eyes on this picture of Dr. Storm. Look for agitation, delirium, stupor, and even coma in severe cases. Uh-oh, trouble aboard the helicopter. That raging fire represents hyperpyrexia, a characteristic finding in thyroid storm. Temperatures can reach up to 41 degrees Celsius in some patients. Similarly, severe tachycardia is also commonly seen. Hence Dr. Storm's heart-shaped pocket watch spinning out of control. A metaphor for the fate of the helicopter? You be the judge. With severe tachycardia comes other tachyarrhythmias, such as AFib, which is frequently seen in patients with thyroid storm. Because of these cardiac effects, thyroid storm is a well-known cause of high-output heart failure, represented by our recurring sketchy symbol, the floppy heart balloon. High output heart failure often leads to hypotension and shock, represented by those lightning bolts painted on the side of Dr. Storm's helicopter. Fitting imagery. The diagnosis of thyroid storm is made based on the presence of these characteristic clinical manifestations combined with the classic lab findings of hyperthyroidism. Let's summarize the clinical presentation of thyroid storm in a sample assessment statement. Aurora Monroe is a 30-year-old woman with no significant past medical history who was admitted overnight for a left femoral fracture from a motor vehicle accident, now post-op day 1 status post-open reduction and internal fixation. She now has acutely developed altered mental status. Vital signs are significant for a temperature of 40 degrees Celsius and a heart rate of 160. Labs are significant for a near zero TSH and elevated free T4. In light of these lab results, Ms. Monroe's presentation is very concerning for thyroid storm. Thyroid storm is a life-threatening medical emergency. So, what are you waiting for? It's time to do something. Just like in run-of-the-mill hyperthyroidism, start beta blockers, represented by that beta bugle-shaped Gatling gun on Dr. Storm's helicopter, for symptom control as soon as the diagnosis of thyroid storm is made. Likewise, a thionamide, either PTU, represented by the PTU sounds coming from that gun, or methimazole, represented by the top secret math papers in that agent's bag, should also be started immediately to block further thyroid hormone synthesis. So far, the initial treatment of thyroid storm isn't all that different from management of non-emergent hyperthyroidism. Well, that's all about to change. See that crate our stuntman secret agent is hanging from? That represents, well, iodide containing solutions such as potassium iodide, which are used to block the release of thyroid hormone from the thyroid gland. Note that the iodide should be given at least an hour after thionamides to prevent the iodine from being used as a substrate for new hormone synthesis. So, we've blocked thyroid hormone synthesis and release from the gland. There's just one more site to work on, and that's peripheral conversion of T4 to T3. Fortunately, we have a treatment for that. Systemic glucocorticoids, such as hydrocortisone, reduce peripheral conversion of T4 to T3 and should be given to patients with life-threatening thyroid storm. Hence those moon-faced discs being thrown by that secret agent. And that ivy he's hanging from? That's to remind you that in thyroid storm, glucocorticoids should be given in IV form for rapid onset of action. Once a patient recovers from acute thyroid storm, long-term management of the underlying disease needs to be addressed in order to prevent this life-threatening complication from occurring. That usually means definitive treatment with radioactive iodine or thyroidectomy for patients with the most common causes of primary hyperthyroidism. Let's wrap up with a brief overview of everything we've learned in this sketch. Hyperthyroidism commonly manifests with a number of symptoms of a hyperactive metabolism, including nervousness, anxiety, heat intolerance, diaphoresis, weight loss, palpitations, and hyperdefecation. In addition, your patient may complain of symptoms common to both hyper and hypothyroidism, including proximal muscle weakness, abnormal menstruation, and psychiatric symptoms like agitation, insomnia, psychosis, and depression. The most common cause of hyperthyroidism, by far, is Graves' disease, an autoimmune condition most commonly seen in young women that results from the production of TSH receptor activating autoantibodies. After Graves' disease, the next most common cause of hyperthyroidism is toxic nodular thyroid disease, which includes toxic multinodular goiter and toxic adenoma. Beyond the big three, the other causes of hyperthyroidism include certain types of thyroiditis that can cause transient hyperthyroidism, such as subacute thyroiditis, silent thyroiditis, and postpartum thyroiditis, ectopic hyperthyroidism from thyroid cancer mets or struma ovarii, exogenous thyroid hormone intake, and various medications, including iodine-containing contrast and amiodarone. On exam, look for tachycardia, systolic hypertension, hand tremor, lid lag, and hyperreflexia. Be aware, however, that not all of these signs have to be present for you to make the diagnosis. The specific characteristics of the goiter you may see in patients with hyperthyroidism can tell you a lot about the underlying etiology. For example, Graves' disease typically produces a non-tender, diffusely enlarged thyroid gland, Whereas toxic multinodular goiter usually produces a non tender, irregularly enlarged gland with multiple nodules. Toxic adenoma classically presents with only a single non tender thyroid nodule. If you palpate an exquisitely tender, diffusely enlarged thyroid, your patient most likely has subacute thyroiditis. Finally, patients with Graves' disease classically present with a couple of very unique exam findings: ophthalmopathy, most commonly manifesting as proptosis, and pretibial myxedema. While the symptoms and signs may clue you in, the diagnosis of hyperthyroidism relies on lab results. In most cases, start with a routine serum TSH. A low TSH indicates primary hyperthyroidism. Follow that up with a reflex free T4. A high free T4 is diagnostic of hyperthyroidism. In rare cases, you may see an elevated TSH along with a high free T4. This is indicative of central hyperthyroidism, most commonly caused by a TSH secreting pituitary adenoma, and it's super rare compared to primary hyperthyroidism. When your patient's labs suggest primary hyperthyroidism, it's time to do a little more digging to figure out the underlying cause. The first thing to do is order a TRAB test, which looks for thyrotropin receptor antibodies. A positive TRAB test confirms the diagnosis of Graves' disease. Otherwise, move on to radioiodine uptake testing, which can help distinguish between Graves' disease, toxic multinodular goiter, and toxic adenoma. Graves' disease will produce a picture of diffusely increased uptake throughout the thyroid, whereas toxic multinodular goiter will result in multiple patches of increased uptake surrounded by decreased uptake everywhere else. Similarly, toxic adenoma will produce a single site of increased uptake with decreased uptake everywhere else. Meanwhile, hyperthyroidism with low radioiodine uptake indicates that the excess thyroid hormone is not coming from the thyroid gland. This suggests that the cause may be ectopic or exogenous hyperthyroidism. The management of hyperthyroidism has two main goals: symptom control and treatment of the underlying cause. Symptomatic control is achieved through beta blockers like atenolol or propranolol. Medical treatment with thionamides like methimazole or PTU is the initial therapy for most patients, whether it's monotherapy or as a way to achieve euthyroidism before more definitive therapy is given. While methimazole is the preferred drug over PTU due to the lower risk of hepatotoxicity, PTU is preferred in the first trimester of pregnancy because methimazole has a greater risk of teratogenic effects. Both methimazole and PTU are associated with agranulocytosis. Thionamides are typically not very effective in achieving permanent euthyroidism, so other, more definitive therapies are often required. The most common definitive therapy is radioactive iodine therapy, and it's preferred for most non pregnant patients with hyperthyroidism requiring therapy beyond thionamides. However, they are absolutely contraindicated in pregnancy. Additionally, if your patient has Graves' disease, take caution before prescribing radioiodine therapy. Patients with mild Graves' ophthalmopathy should be given oral glucocorticoids concurrently to prevent worsening of eye disease. If the ophthalmopathy is moderate or severe, you shouldn't prescribe radioiodine. In these cases, surgical thyroidectomy is the best option. It's also preferred in patients with large obstructive goiters and pregnant patients who are allergic to thionamides and therefore have no other option. Thyroid storm is a rare, life threatening condition characterized by severe symptoms and signs of hyperthyroidism that typically occurs in patients with undiagnosed or inadequately treated hyperthyroidism who undergo an acute event like surgery, trauma, infection, or a large iodine load. The hallmarks of thyroid storm include altered mental status, hyperpyrexia, and tachycardia. Diagnosis of thyroid storm is similar to that of regular hyperthyroidism. Characteristic lab findings in the setting of a patient with classic symptoms. Treatment is similar too: beta blockers to treat the symptoms, and thionamides to stop thyroid hormone synthesis. In addition, iodine containing compounds are given, after thionamides, to block the release of thyroid hormone from the gland, along with IV glucocorticoids to block peripheral conversion of T4 to T3. And there you go. Our suave, debonair secret agent saves the day again. Oh, what did you expect him to do?